welcome to our webinar, Lung Health in a Changing Climate. I'm Dr. Stephen Gay, Professor of Internal Medicine in the Division of Pulmonary Critical Care at Michigan Medicine, and I'll be your moderator today. We are pleased to welcome you to the CME presentation presented by the Division of Pulmonary and Critical Care here at the University of Michigan. We believe there has never been a time when the environmental threats to lung health have been as great as they are today. We, as pulmonary providers, are on the front line, but this isn't an area of medicine that is often included in traditional training programs. Our goal for today will be to help educate you on some of the emerging environmental threats to lung health so that you'll be more knowledgeable and better able to advise and care for your patients. For our webinar today, we'll be leading off with a talk on wildfire and air pollution by Dr. Alex Rabin. Dr. Rabin is a clinical assistant professor for pulmonary and critical care here at the University of Michigan and at the VA Ann Arbor Healthcare System. The goal of his work has been to understand the effects of air pollution and climate change on patients with respiratory disease and to minimize the environmental impact of healthcare delivery through research, education, and advocacy. His current project, titled VA Switch, is investigating the clinical effectiveness and the relative greenhouse gas emissions of metered dose versus dry powdered medical inhalers. His writing has been featured in the New York Times and the Los Angeles Times. A graduate of the Emory University School of Medicine, Dr. Rabin completed his medical training at Brigham and Women's Hospital and the Mass General Hospital. We will follow that on a talk by Dr. MeiLan focusing on environmental threats to lung health over the lifespan. Dr. Hahn is a professor of medicine and chief of the Division of Pulmonary and Critical Care here at the University of Michigan. Her research experience is in airway disease. She's a national spokesperson for the American Lung Association and is also a member of the Global Obstructive Lung Disease Scientific Committee, which is charged with developing an internationally recognized consensus statement on COPD diagnosis and management. Relevant to today's talk, she is also the author of a book on lung health for the lay public entitled Breathing Lessons. We will begin with both presentations. Afterwards, there will be time for questions and answers after both presentations have concluded. Please use the Q&A feature at any time to submit your questions, but the questions will not be addressed until both speakers have been completed. You will receive an email after the course adjourns with instructions on how to obtain your CME credit. And now, without further ado, Dr. Alex Rabin.
Thank you so much, Dr. Gay, for the kind introduction. As I just get my slides pulled up here in just a moment. Everybody can see that okay, I hope? Okay, so we shall get started. So thank you again to Haley Seymour from the CME office and to Dr. Gay and Dr. Hahn for this kind invitation. It's really an honor to be here talking about the issue that has really consumed my work and life over these last years, and about a topic that I feel very, very deeply and which I think is increasingly important for all of us as care providers to know something about and to be able to share that information with our patients. So today I thought I would focus my talk on wildfires, in particular because this was a health effect. The health effects of wildfires became imminently obvious after the massive wildfires which occurred this past summer in Canada, and whose smoke greatly impacted our patients here in Michigan and really across the country. I have no relevant financial disclosures. I do want to just acknowledge that I'm an employee of the U.S. Department of Veterans Affairs, but the views expressed in this presentation do not necessarily represent those of the government. And my work, as mentioned, is supported in part by a grant from the Department of Veterans Affairs. The objectives of my talk are to first recognize the increasing burden of wildfires in a changing climate, then review the respiratory health effects of smoke exposure on patients, including vulnerable populations, understand the role of health professionals like yourselves in managing smoke exposure, And lastly, to briefly explore the role of healthcare professionals as climate advocates to both minimize our own contributions to climate change, as well as advocate for greater government policy change. It goes without saying that the climate is changing and these effects are being felt globally. In case you haven't looked at this graph recently, it's always kind of it's seared into my mind, and that is that our CO2 levels, which as of last month have now reached 421.86 parts per million as measured on the top of Mauna Loa in Hawaii, are at levels that have not been seen in about 3 million years. And at that time, of course, there were no humans on Earth, and temperatures around the globe were somewhere between 2.5 and 4 degrees Celsius hotter than they are now. And sea levels were between 16 and 82 feet above what they were in the year 1900. So we are really in a time of unprecedented change when it comes to the climate. Now, of course, these effects are felt globally. There really isn't a pocket of the Earth where the climate isn't changing. But in northern latitudes, including places like Alaska and in the northern islands of Norway, the effects are very dramatic. But in Michigan as well, it's very clear that increased temperatures here are changing weather patterns, even on a year-to-year basis. And here you can see the linear trend of temperature increases over time from the end of the 19th century until a few years ago. What does the warming do? Well, really, there are many effects on the environment, but the one that we'll speak about today is the effect on wildland fires. As lands dry out, as droughts expand in intensity and magnitude, and as land use changes, patterns change, as well as how where humans are living at the urban wildland juncture, we've seen a vast expansion in the number of acres burned, really across the globe. And as you can see from this report put together by the Lancet in 2021, many parts of the globe that are seeing even the greatest increases in the number of days of exposure to wildfires also happen to be those areas that are the most vulnerable to health impacts and have the least resources to deal with them. Bringing us back to this past year, of course, what happened in Canada, it's hard to even kind of wrap your head around how severe and how unprecedented, and again, we use that word a lot when we're talking about climate change, but really how unprecedented this wildfire season was. In 2023, over 45 million acres of land burned, and that's an area about the size of the state of Washington, larger than the size of all of North Dakota. And that's actually an amount of land that's roughly similar to the Australian bushfires. If you recall, in 2020, vast stretches of Australia burned, about 45 million acres burned at that time as well. 46 million acres burned in 2020. Again, just to put this in perspective, 2020 also happened to be a very severe wildfire year in California, and at that time, about 4.5 million acres burned. So this was something about 10 times that scale. And in fact, the fires are still happening even through the winter, and it's believed that they're largely kind of smoldering underground, and the fires will resume once the spring thaw happens. So these are really, really severe impacts on the landscape. Now, for people who are living in the immediate vicinity, including many indigenous communities, but also smaller towns and villages in Canada, of course, one can hardly imagine what it feels like to live there. And in fact, there were cities that were towns and cities that were evacuated this past summer. But the smoke, of course, doesn't just impact the health of those people who are living in the immediate vicinity, because the just enormous plumes of smoke that are produced from wildfires travel. And when they travel from depopulated areas or minimally populated areas to vast areas, for example, in the East Coast or in the Midwest, then you are exposing a large number of people, including many, of course, people who already have pre-existing health conditions like asthma and COPD, to noxious smoke. Now, again, I want to emphasize that the dose and the type of smoke that people are exposed to, say, in on the East Coast from Canadian wildfires, is quite different from the smoke that's produced in the immediate vicinity of the fire. And yet, again, just because you have the sheer number of people now exposed to these wildfires, it creates really major public health concerns. And I think this is in part why the wildfires that happened in Canada really got a lot of people's attention, because it was affecting the East Coast in a way that we hadn't really seen in recent years. I know, as Dr. Han will talk about in her presentation, um, wildfires are really a major concern, because they have contributed to backsliding in really decades of very successful policy efforts to clean up the air that have occurred thanks to really smart decisions made back in the late 1960s, when the California Air Resource Board was established, and then into 1970, when under Richard Nixon, the EPA was established with the first iteration of the Clean Air Act. Air quality has generally improved. However, because this proliferation of wildfires, particularly in the western United States, we are now seeing larger populations of people exposed to very high levels of fine dust pollution. And in this one analysis published last year, or 2 years ago, excuse me, comparing a baseline from 2006 to 2010 to more recent times, 2016 to 2020, they found that the number of people in locations with at least a day of very elevated fine dust pollution increased over 25 times. Now, what's in wildfire smoke? Why are we as lung doctors or lung health professionals concerned about wildfire smoke? Well, it's important to note that your average campfire does not equal what's produced from a wildfire. And that's because, as I alluded to earlier, because of the nature of wildfires, which can consume uh, houses, cars, other man-made structures, the types of materials that are produced and combusted can really be a very noxious cocktail of substances. And here are some of the delicious things that wildfires produce, I've said facetiously. That said, the one that's probably best studied, and the one which we know the most about, is particulate matter. And essentially, this is fine dust that's suspended in the air, and it's a mix. It's not a specific compound. It's basically described by whatever's suspended in the air, typically produced by combustion. Now, your average particulate matter is largely in sort of in a non-wildfire location, is largely produced from combustion, from fossil fuel combustion of power from power plants and cars, but also dust from, for example, from natural processes, from agriculture as well. So it's this dust that's suspended in the air. And when wildfires burn, they produce just vast quantities of particulate matter. And the particulate matter is broken down by size. And the reason the small particles, of course, are of great concern is because they can penetrate deep into our lungs, into the tiny bronchioles. The even smaller particles, the ultrafine, which is less than a micron, can even get into our bloodstream. Now, I put up here, and this is important because from a policy standpoint, this is actually currently under very active debate about what the EPA should set as our standards for the United States. The current standards for particulate matter exposure for a 24-hour period are currently 35 micrograms per meter cubed, whereas the annual standard, in other words, the amount of particulate that's allowable for a year, averaged over 3 years, is 12 micrograms per meter cubed. Now, again, just to put this into perspective, from an analysis of the 2018 Camp Fire, it was not uncommon for areas of California to see 24-hour levels exceed 250 micrograms per meter cubed. So very, very high doses of particulate matter exposure occur, especially in immediate proximity, excuse me, to the fire. Again, why do we care so much about particulate matter? Why do you hear about it in the news quite a bit? Well, again, because it's really the best studied air pollutant, that and ozone. These two are kind of the ground level ozone, kind of the best studied respiratory irritants. And as years and really decades of study have shown, particulate matter is very dangerous and actually is linked to increases in mortality. And that mortality signal is probably best linked to cardiovascular outcomes, heart attacks and strokes, but also respiratory related mortality. And this seminal study published about almost 5 years ago, in the New England Journal of Medicine, showed that even short exposure over a 24 to 48-hour period to increased concentrations of particulate matter have a near linear relationship with mortality. So short exposure leads to an increases in concentration over very short periods of time, lead to increases in mortality. And again, just to reference where we are as compared to the current national air quality standards, which are currently for a 24-hour period set at 35 micrograms per meter cubed. You can see that line to the right of 25. And what you notice is that even at lower levels, there still seems to be sort of a concentration response curve. In other words, there isn't really a safe level. Even at very low levels, there is an increase. There's a relationship to increased mortality. So this is part of the reason that people really are concerned about particulate exposure, including from wildfire sources. As mentioned, though, it's not just particulate matter. There are other significant toxins produced when you burn a lot of biomass, including carbon monoxide, of course, but also metal oxides, hydrogen cyanide, phosgene, dioxins. And again, these largely are a result of the wildland-urban interface, where essentially you're burning artificial man-made structures and then releasing a lot of these very, very toxic chemicals, which are known in some cases carcinogens. So what do we know about actually wildfires and asthma or COPD? Well, these have been really, especially asthma, has been really, again, very extensively studied through a number of epidemiological studies, many of them coming from California, Australia, where researchers have gone back and looked at what happens with short-term exposure to wildfire-related particulate matter. And they found, again, I just gave us a couple of sample studies, but there are many others out there, that in general, as expected, when you take people who are healthy, and particularly those who are unhealthy, who already have pre-existing respiratory disease, and you expose them to high levels of wildfire particulate matter, they go to the emergency department and they get hospitalized at higher rates than those who are not exposed. In this particular study of asthma, females and adults seem to be in the higher risk groups. Among those with COPD, again, there's a smaller body of literature, but again, convincing that hospitalizations and physician visits increase, as well as increases in rescue medication use. And as we get better at studying this, we can get this data relatively quickly. And in fact, just in September, I believe, after the massive wildfire events, the biggest events from Canada came down and affected New York City, there was a letter already published in the Journal of American Medical Association in JAMA in 2020, last fall, 2023, showing again this sort of very clear relationship between high levels of particulate matter that affected New York, as we all probably saw those images of the red sky when levels of particulate reached above 100 micrograms per meter cubed. And as a result, asthma-related emergency department visits went up. Now, again, I want to emphasize that these effects are felt. These effects are not felt equally. Even in a place like New York City, where, as you might expect, where people are already more vulnerable, have more pre-existing conditions, are younger or elderly, they they are at a greater risk for asthma-related hospitalizations and emergency visits. Children are an area of particular concern, and that's for a variety of reasons. One is that there is recent data, including this important paper that was published in Pediatrics in 2021, that suggested from wildfires that occurred around San Diego that the particulate matter released from wildfires seemed to be it seemed to result in more than 10x greater increases in emergency department and urgent care visits, suggesting that something about that particulate matter is more toxic to kids. It could be just that there's again this cocktail of substances that are released that are particularly dangerous to children. Of course, children also are just more vulnerable because they tend to be outside more. They breathe faster relative to their body size, and so and of course they have many years ahead, and their lungs are still developing, and so they are a particular area of concern. And I think for as a parent of two little kids, I certainly felt that a lot, and as we worried about sending our kids to school when the smoke was really bad here in Ann Arbor. Just to further underscore this point, I thought this was a really interesting analysis that was done in 2017, underscoring the point that really, while everybody's affected by the air we breathe, communities that are already vulnerable to health disparities are at increased risk. And this study tried to overlay kind of vulnerability risk, looking at pre-existing conditions, socioeconomic status, and then overlaying that over kind of the wildfire smoke areas that may be affected, and tried to develop this vulnerability index. And as you can see, kind of the western slope of the Appalachian Mountains, those areas seem to be at higher risk. But also areas of Michigan, as you can see, are darker red, mostly indicating that there are a lot of health disparities in these particular areas. So a question that I get a lot is, okay, well, what about, we know that it makes sense, short-term exposure to wildfire smoke can't be good for your lungs, especially if you're already suffering from asthma or COPD. But what about the long-term effects? And although less is known, and I should emphasize that for most people, healthy people, exposure for a few days to higher levels of particulate matter, it's probably relatively unlikely to have very long-term effects for adults. That being said, there is now concerning data. This paper got some press very recently, suggesting that other carcinogens are being released. And in this study, basically researchers went out to an area of California that had burned and did soil sampling and discovered that, to their surprise, they found evidence, high levels of hexavalent chromium, which is a known carcinogen. And basically what had happened was the precursors were found in the soil ahead of time, and likely what happened was the fires burned so hot, which is something that's happening with climate change. Fires are burning hotter and longer, that there was a chemical reaction and converted this chromium into this hexavalent form. And why is that a concern? Well, because that's a hexavalent chromium is a known carcinogen, has been linked to lung cancer. So again, not to not to scare people, but it is a concern that some of these carcinogens could be released, especially most acutely for those in the immediate vicinity of wildfires. So back to Michigan. We've talked a lot about California, but back to Michigan. Um, Speaking from my own experience, I can tell you there were large numbers of patients in my own clinic where I work at see patients at the VA, and many of my patients have COPD, and many of them were not only just concerned, but many of them reported increased symptoms. Some of them required additional treatments, medications for exacerbations. Some came to the emergency department. It was very noticeable. I'd say anecdotally, I'm sure we can talk about that more, about what our experiences were after this past summer. Some of my colleagues even told me that for the first time in my life, I felt like I had asthma. That was actually our section chief told me that. And others told me that, I've lived in Michigan my entire life and we've never experienced anything like this. And so some of this contributed among staff, myself included, to a significant amount of eco-anxiety, or just concern about like what's going on in the world and how are we going to deal with this. So, I try to channel that eco-anxiety into action. And the first thing I think that we should all be thinking about is, how do we actually counsel our patients? And there are a number of recommended approaches, including those recommended by CDC. But I've put some of them up here, and I wanted to briefly review them, and we can also talk about them further in our Q&A. But these, I think, are some of the key interventions. I think the most important thing to start is that patients are aware of what's going on. And while a lot of people are tech savvy and have now air quality monitoring easily available on their smartphone, others, especially the elderly patients who don't have smartphones or don't have regular internet access, can kind of miss the message. And actually, I found that in a substantial number of my patients actually came to me saying they had trouble breathing and kind of didn't even realize that the air quality was as bad as it was. So that's why we really need public health interventions and better early warning systems. Um, Another very high-risk group that I think gets not enough attention is actually outdoor workers, and basically those people who have to be outside for their occupation, otherwise they lose their job, and thinking about how best to help these folks, and this can be really challenging. Um, when often the main recommendation is to try to stay indoors and minimize exposure to air pollution. So working with patients, trying to think about masking strategies, and now folks are generally well familiar with high quality respirator masks like N95 or better. Those can really help mitigate the risk. Now, of course, it's important that you're able to wear your mask properly if you have to be outdoors. And this intervention can be really tricky, especially because the wildfires tend to happen more so now they happen year round in California, but more so in this area, they happen during the summer when it's really hot. So trying to come up with strategies and action plans for patients is really important. I think one area that I think is very important and uh, demands more research is telehealth, and how can we provide care to patients at arm's length, at a distance, and intervene early if they seem like they're having difficulty during poor air quality events. Medication management is always very important, and making sure that your patient is has best control of their underlying respiratory condition ahead of time going into the event, and has a supply of emergency medications if necessary, whether that's oral corticosteroids, rescue medications, rescue inhalers. All of that is really important to help them get through the event in the event that they do suffer negative health effects. And I think the last piece here, and the one that um, I think probably is perhaps more effective. I think we need more research, but in general is very promising, is improving patients' indoor air quality through air filtration and improving air handling systems. And I just want to briefly mention, and again, we can talk about this more in the Q&A, but um, understanding your air filtration systems. So for folks who have a central blower, like a central AC heat unit, it's important to make sure that they have the best filter that they possibly can can attach to their HVAC system. And so these are rated from 1 to 20, and it's called the minimum efficiency rating, MERV. And ideally, you want to have a filter that's above 13, which will filter out fine particulate matter, or PM 2.5. The problem is that some systems are just not equipped to be able to handle such a hefty filter. So that's where folks really should be talking to their HVAC specialist to see what the options are. For those who can't install or don't have that kind of central blower system, like actually we have an old 100-year-old house which we live in, a second best option may be a HEPA filter, which is essentially a standalone air filter that has a very, very high quality filtration device that can basically, again, get rid of that particulate matter. And this has actually been studied, there are some very small studies in wildfires, but in COPD, this important study came out in the Blue Journal in 2022, randomizing patients with COPD, former smokers, to a HEPA filter or a sham filter. Basically, it had the fan, but no filter. And what they showed, which I think was important and thought-provoking, was that not surprisingly, those who had the HEPA filter and used it, and that's the key, is it's not enough to just have it and standing there, but you actually have to use it, turn it on, and have it at a sufficiently high setting. They were able to get particulate matter and nitrogen dioxide levels down in the house. And there were there were resultant decreases among those COPD patients in exacerbations, and non-significant decrease in rescue medication use. Now, they didn't reach their primary endpoint, which was improvement in the St. George Respiratory Questionnaire, but in the secondary outcomes, it seemed like there was some improvement. So this, again, is a relatively small study. This is, again, not specific to wildfires, but I think logic would suggest that having an air purifier in the room where you're spending the most time uh, uh, can be a reasonable solution, particularly for those people who are at risk. Again, there are a lot of barriers to this, particularly cost, where air filters can easily cost $150, $200, even for a single room. And not only do you have to have the air filter, you have to plug it in and pay for the electricity, and then you have to replace the filter every 6 to 12 months. So there are barriers, and again, these are under active investigation. One neat solution that has been proposed by I believe CDC and others is you can actually make a do-it-yourself air filter, which will cost you definitely less than $100. And this is one possibility, where basically you just take a MERV furnace filter, attach it to a room fan with duct tape or bungee cords, and actually that does pretty good job of cleaning up the air. And there are also better setups where you can make a box out of it. So there can be cost-effective solutions. Very briefly, I do want to just address climate change and air pollution, wildfires, because of course you can't really talk about wildfires and air pollution without addressing the elephant in the room, which is climate change. And I took this photo actually this past summer when the wildfire smoke was really bad, and I happened to be going down to give a talk to a community in Monroe, Michigan. And as you can see, the sun was kind of blotted out. And this is actually the largest coal-fired power plant in Michigan, I think the third largest in the country. And I thought that it was a kind of an interesting juxtaposition between sort of the cause and the effect, because clearly, we individuals, we're not going to be able to change the risk of wildfires, but as a group, we can change how we produce energy and make policy changes nationally and internationally to try to stem the worst effects of climate change. And there are a lot of things that we can do as health professionals. Thinking about how we get from place to place, how do we get to the office or to the clinic? How do we use energy at home and at work? How we power our hospitals. Here at the University of Michigan, we're the hospital and the medical center is really starting to ramp up their approach to climate, and actually recently announced that they signed on to the climate pledge by the Department of Health and Human Services, which was very exciting. And they're pursuing green building. They're encouraging active transportation. We have a pavilion that's being built that's going to be Platinum LEED certified. And we're starting to address supply chain, which is really about 80% of healthcare emissions come from the supply chain. Basically, all the stuff we use in the hospital and the clinic to make all of that stuff releases a ton of CO2. So those are all the things that we're doing at a system level. But there are even like little tiny things that even health professionals themselves can do. And one of the things that I've, as Dr. Gay mentioned, that I'm really passionate about is trying to understand the contribution of pharmaceuticals. And in particular, I've done some work and we've started a new project over this past year, trying to understand better the contribution of metered dose inhalers, which have a propellant which has a high greenhouse gas contribution. Within the VA system, actually, for reasons of cost, the preferred inhaler in 2021 was switched from a metered dose inhaler that has this greenhouse gas propellant to a non-MDI, a dry powder inhaler, which doesn't have any propellant. And so we are looking at this as sort of a natural experiment to understand what impact does it have on patients? Does it really matter with their clinical outcomes in the case of asthma and COPD? And also our sort of second half of the project is to understand the effect on climate-related greenhouse gas emissions in total, to basically understand the net impact of this life cycle assessment. In addition, I think it's really important for health professionals like all of us to really get involved. And I've tried to channel my energies in different ways, channel my eco-anxiety, trying to write about the issue, speak out in state legislative settings. And I've been very blessed to have the support of the faculty and the division on this front, because we have a very powerful voice as physicians and as providers here to make a difference. And so I'll leave you with that, and would love to open the conversation up after Dr. Hahn's talk. So thank you again for having me.
Thank you so much for that presentation, Alex. All right, let's see if I can get my screen shared appropriately. All right. Okay, well, with this section of the talk, I'm going to try to take what Alex has so eloquently described and try to pull back a bit and think about that type of pollution and sort of the greater context of all the kinds of various threats to lung health that we as humans experience over the life course. I, as an adult pulmonologist, was very, I think, focused on kind of more the traditional areas of lung disease that we all learn about in medical school and fellowship until the pandemic hit. And for me, that really got me thinking about not just respiratory threats, but sort of all of the threats to respiratory health, and how we can be better prepared as both lung doctors and citizens in the future. So let's see here, my disclosures. So I told you that part of this talk for me at least started with the pandemic. And one of the things that was so distressing to me as a pulmonary and critical care physician was the number of people that died from COVID-19. And when you look at what it is that people died of, the number one cause was respiratory failure. And then in many other cases, other organ failure. But I think we all know who critical care physicians and people who work in the ICU know that usually respiratory failure is some piece of that multi organ system failure. And in fact, in 2021, for the first time ever, lung disease was actually the number one cause of death in the United States. And so, similar to Alex, I like the way he described that, trying to alleviate some of his own anxiety. I had also written this piece in the LA Times about 2 years ago now, just kind of outlining my thoughts. And that's what some of what I'm going to share with you today. And that's just the fact that, even before the pandemic, lung disease was already third leading cause of death in the world. And we have so far to go in understanding all of the things that go on that can influence lung disease. And so that's what I'm going to talk a little bit about today. But just to give you a little bit of historical context, we have poured a lot of money into solving heart disease. And because of that, we've really made great strides when we think about statins and beta blockers and stents and just all the things that we can do now. We've seen dramatic decrease in the last 50 years or so in the rate of death from heart disease. At the same time, however, we've seen an increase in overall deaths from chronic lung diseases, and in particular COPD. Now, I don't think that that's because lung disease has necessarily become more deadly. I think it's that we've solved some problems and people are living long enough to die of other problems. But I think it does underscore the fact that we need to do a better job of understanding all of the factors that go into developing lung disease, and seeing what we can do to try to eradicate it. I will tell you that right before the pandemic, I think, and many of you may be familiar with this data, but this study that came out in the New England Journal of Medicine was published back in 2015, I think really got a lot of us thinking about lung disease differently. And that's because in this particular study, what they demonstrated was that they put together 3 population-based cohorts and tried to the best they can, trace out lung function trajectories over the life course, and tried to understand who it was that developed COPD. And that's this group. Let's see here. That's this group here. And the traditional thinking has always been that everyone reaches normal lung function, and then those who are exposed to tobacco would have more rapid lung function decline, which is this red line. But what this study showed us is that there's actually an similarly equal, if not more, number of people who actually never hit peak lung function in the first place, and actually have more of a normal age-related decline in lung function in adulthood. Which, if you think about it, given them, I think we have, probably about 15 million diagnosed and 15 million undiagnosed individuals with COPD just in the United States alone. That's a lot of people who are not hitting peak lung function, but we never check lung function routinely, only when patients have symptoms. And at that point, the lungs have a lot of reserve. So at that point, we've already, lost quite a bit of lung. So it's quite concerning. And so what it got me thinking about was, well, what's going on in here during childhood? I am not a pediatric pulmonologist, but I have spent some time over the last few years really trying to understand what could be going on. And so I now tend to think of the lungs with respect to lung health in sort of three basic chunks. And that would be the prenatal period, childhood, and then adulthood. So I'm going to spend just a few minutes today talking about each of those stages of life and what some of the potential threats to lung health are for each stage. So just to remind everyone kind of how the lungs develop, when they develop. The lungs are mostly formed and developed at the time that babies are born, but not fully developed. And so it's also important to remember that the lungs continue to grow and expand up through probably mid 20s, which I think is really important when we think about things like when legalization of and ages at which smoking is allowed, et cetera, things like that. And it is actually male infants in particular that are at increased risk due to slightly later development of surfactant that helps to protect the developing alveoli. Uh, and with the improved technologies that we have that are allowing children to be born earlier and earlier, I think what's not known is to what extent we're going to have sort of perinatal threats to lung health actually manifest later in life, uh, and to what extent, to what numbers that's actually going to occur. We're doing a better job of caring for those infants such that they're healthier, but we have more and more of them, and we're able to save earlier and earlier and younger infants. So I think this is something, again, because we do not routinely check this. I recently had a young gentleman in my clinic who was noticing that he was short of breath and playing basketball with his buddies. He'd started vaping in his mid-teens, and after we did some digging, it turns out that I think it's likely he had bronchopulmonary dysplasia from preterm birth. And if he had been known to the system, and if he and his mother who accompanied him had known that he was at such high risk, I think he would have potentially made other life choices than to start vaping. And this is why I continue to wonder whether we're really doing ourselves a disservice by not pushing for more routine lung function testing like we do, for instance, blood pressure testing. So when we just look at maternal fetal health and preterm births, what is kind of striking are the high numbers of preterm births, particularly in the United States when you compare us to other Western countries. It's not completely clear why that is the case. Do we just have bad prenatal care here in the US? The other possibility is that due to obesity, other chronic conditions, or the high rates of assisted reproductive technologies may all contribute to higher preterm birth rates, particularly in the United States. We think about tobacco exposure in adulthood as being important, but we forget sometimes, I think, about the importance of in utero nicotine exposure. So if you look on this graph, you can kind of see a range for the prevalence of maternal smoking during pregnancy, but in some countries, it's as high as almost a third. And interestingly, even though babies aren't technically breathing tobacco smoke, there is still an increase in wheezing, respiratory illness, and asthma among children who are born to mothers who smoke during pregnancy. The interesting thing is that the data suggests, at least animal models suggest, that exposure to nicotine in utero can cause the development of long and tortuous airways that would predispose a child to airflow obstruction. And interestingly, you may not be aware that of course, smoking cessation is the #1 goal, but there is some interesting data to suggest or actually two studies looking at vitamin C supplementation to pregnant smokers, and that this may actually provide some protective effects on fetal respiratory health. When we think about lung health sort of in those childhood years, again, it's, I think, interesting to take a moment and think about all of the data that's come out in the last few years on lung function trajectories in childhood. There are all sorts of things that can happen. Children can be born with low lung function and then catch up. Others have supernormal lung function, and then all sorts of things happen. And again, because we don't routinely capture any of this information, we just, unless it's part of a study like this one, it gives us, it puts some blinders on to a certain extent when we start assessing these people in adulthood, because we don't really know exactly where they started and whether their current lung function is actually good for them or not. But some of the things that can happen in childhood that can impact lung function include things like pneumonia, which is the one of the number one causes of death for children under 5. But other things like breastfeeding, which can help to reduce lower respiratory illnesses, childhood immunizations. We've seen some exciting developments on that front in the last few years. RSV infections are still a major cause of respiratory morbidity and mortality among young children in particular. And all of these things can ultimately have an impact on adult lung health. Uh, Alex already touched on the importance of air pollution, generally speaking, but there is evidence of the impact of air pollution and what it can do to sort of to human lungs throughout the lifespan. So, for pregnant women who are exposed, it can result in low birth weights. In children who are exposed, it can result in asthma, slower development of lung function, more problems with wheezing and coughs, asthma exacerbations. Once you move into adulthood, air pollution, there's some interesting new data to suggest that the microparticles are actually probably absorbed into the endothelium and can actually have direct impacts on the vascular system in addition to the respiratory system. And we now know there's pretty good evidence that air pollution can cause not just exacerbations of things like asthma and COPD, but it can actually promote the development of both. One of the most interesting pieces of data to me that came out during the pandemic was this study that was looking at the relationship between wildfires and deaths from COVID-19. And what they found was, this was a really unique opportunity to examine a very isolated exposure, which were some of the wildfires that were occurring in the American West during the summer of 2020. And then an infection that was being more closely monitored than probably any infection at any time ever. And so they were able to very closely relate exposure in terms of PM 2.5 to COVID-19 infections and deaths. And what they found was that there was an association between wildfire exposure and an increase in both COVID-19 cases and COVID-19 deaths. So to me, this is just really, I think, astounding when you think about it, because while we had known that air pollution exposure can increase your risk for respiratory infections, we'd never seen it described in such a granular way. And think about all the things that we're exposed to on a daily basis that probably cause micro lung injury. I bet the majority of those individuals probably didn't know that they'd experienced some lung injury, and how that kind of subtle, probably subclinical lung injury then contributed to an increased susceptibility for exposure to yet sort of another hit. And so think about, all of the things that we're exposed to on a daily basis, and what other things that micro lung injury, subclinical lung injury that many of us may be walking around last summer when we had all the wildfires here in the Midwest, and what that can do. It makes me wonder about to what extent underlying lung disease or lung injury from a variety of unknown factors probably contributed to the heterogeneity in COVID-19 susceptibility and deaths that we saw. Over and over, we kept saying, I don't understand why this individual did great and this individual, died. And I think that it's possible that it could be factors like this that contributed to, again, the heterogeneity we saw in COVID-19 susceptibility and mortality. Alex already touched on this, so I won't get into it too much, but generally speaking, as he mentioned, global air quality is getting worse. And that's from all sorts of things, whether it's combustion of gasoline and wood, construction, fossil fuel combustion, traffic, et cetera, et cetera. There's many, many things that are unfortunately are contributing. This just is a map that zeroes in a little bit more closely on what's going on here in the United States. We don't talk about indoor air pollution quite as much. Now, certainly outdoor air pollution can cause indoor air pollution, and that's why, as Alex mentioned, when we've got wildfires and things like that going on, we try to recommend people to try to tighten up the house and start running the air filters. But indoor air pollution can also, coming from sources within the home, is another important factor we have to think about when we think about uh, how the air we breathe impacts lung health. Now, traditionally, the thing that I think in the respiratory community have talked a lot more about actually um, relates to things like biomass fuel, and which women cooking over wood burning stoves, like in China, India, and Africa, et cetera, et cetera. But that's certainly not the only place that people might be exposed to air pollution in their home. It's still a problem within North America and Europe as well. Another area, particularly for children, that we probably don't think about enough has to do with outdoor air pollution from traffic and particularly idling long car lines at school. So there's some really interesting research suggests that residential distance from a highway has been associated with lower lung function among children, and it improves when children are moved out of that environment. So when we think about things like city planning, we have to think about where we're putting our schools. You really don't want your schools near freeways or heavy traffic. And if possible, schools should adopt anti-idling policies. The EPA has some examples of what that can look like. But the long car lines that we've all gotten used to during the pandemic, unfortunately, are not a great thing, and people need to turn their cars off when they're waiting for their kids. Circling back to the indoor air pollution concept, I mentioned that there are definitely things within the home beyond things like cooking over a wood burning stove that can cause indoor air pollution. This can range anywhere from the kinds of chemicals we use in our homes to things like radon and wood burning stoves for heating. The volatile organic compounds are present in many things within the home. And if you're trying to counsel people to try to avoid them, the EPA has a list actually on their website of kind of healthier choice products in terms of cleaning products. But I recommend looking for low or no VOC paints, which are increasingly available now. You can even recommend having your carpet actually aired out prior to installation. I did both of these when remodeling my basement this last year. Every home needs to be tested for radon. It's the second leading cause of lung cancer. And, I grew up in Idaho. I had a wood burning stove in my home. They are not uncommon in North America as an adjunct, cheaper way to heat your home in the winter. But unfortunately, they have also been associated with increased risk for COPD, particularly in women. And this is where, while there's no such thing as an absolutely clean burning stove, you want to point patients, if possible, towards some of the newer, cleaner burning models. There's a lot in the news this last year on the relationship between indoor gas stoves for cooking and the risk for asthma. And unfortunately, the situation got highly political, but there is a lot of data, and this has been around for years. What kicked off the discussion was really a meta-analysis that got published on the old existing data, but this has been known for years. And I just wanted to point you to one interventional study that I'm aware of that was done on this topic. And what they did was they randomized homes to either, we're going to switch out your stove to an electric model, we're going to give you an air purifier that you can run in your home, or we're going to give you a vent hood. And what they found was that the best was the stove replacement, followed by running an air purifier, and the worst was the vent hood. Now, that doesn't necessarily mean the vent hood doesn't work. We don't know from the studies how much people remember to turn on the vent hood. But at least from the data we have, it would suggest that either replacing the stove or running an air purifier may be better options, but I'm certainly not telling my patients not to run their vent hoods. I don't think it hurts. It's just unclear that it's as helpful as some of these other options. Unfortunately, we still have quite a few children in the US that are exposed to secondhand tobacco smoke within their homes roughly 40% of US children aged 3 to 11 are still exposed to some form of secondhand tobacco smoke, which leads to a large number of deaths in addition to exacerbations of underlying other respiratory conditions such as asthma in children. Unfortunately, if you'll remember, before we got really swept away with the pandemic, the vaping epidemic and the vaping youth crisis was really kind of burning across the headlines right before the pandemic hit. And the problem, however, has not gone away. Our focus and attention on it in the public may not be what it once was, but the problem itself has not gone away. Most recent estimates suggest probably a quarter of high school students in the US have at least tried some type of tobacco product, with the majority having vaped electronic cigarettes. The FDA has been very, very slow to regulate this, and there are multiple companies that market flavored products. They look like, just looking at my desk here, they can look as simple as like a USB. It could be even on a countertop at home and you wouldn't even know it. The experts recommend that if you're going to talk to children about this, middle school is probably the best time to start initiating conversations with children about the dangers of vaping. And I can tell you, we're running a lot of studies here at the University of Michigan on individuals 25 to 35 and getting a lot of CT scans, and I am seeing a lot of vaping and marijuana-induced lung injury on these CAT scans. We would never know because the patients aren't complaining. We're just getting the CAT scans as part of a clinical trial. So just moving on now to adulthood, this might be where most of us are a bit more comfortable, but the point that I want to reiterate is that it's not just people who smoke who are going to be at increased risk for lung disease. There's all sorts of dusty and dirty jobs that people have, and we need to talk to them, make sure they're using appropriate respiratory equipment. And then there's other jobs where I think the threats are a little bit more nebulous, but things like nail technicians, hair salons, et cetera, where I think people don't typically wear masks. And I think we're still trying to understand exactly what the risk to workers in those environments actually are. But the problem with this, this is one of the occupational lung disease stories that did hit the headlines this last year. And this is really unfortunate because these workers were not protected. So there was a case series of 52 patients that was published in JAMA Internal Medicine just this past year, related to countertop fabrication. And it was a series of 52 gentlemen that had come to the attention of the occupational health system in California that were all in the business of engineering stone countertops, where they really need to be wearing adequate protection. We all heard about it, but I actually was looking through the paper again in preparation for this talk, and I have to admit I was really upset. When I looked at it, because 19% of these individuals were uninsured, 51 were immigrants, 19% of the cases were fatal. 3 ended up needing transplants. 1 didn't even make it to transplant. And so we are not doing an adequate job of clearly protecting our workers when it comes to these kinds of threats. I mentioned a minute ago that we're doing some studies here at the University of Michigan where we're looking at young people. And here's just some examples of some of the things that we're seeing even related to tobacco exposures in young individuals, where we're seeing things like gas trapping. We're seeing central lobular nodules consistent with respiratory bronchiolitis and early emphysema in individuals 35 to 45, where again, often we aren't actually looking for disease, but we can definitely pick it up on CAT scan. So I know that both Alex and I spent a lot of time talking about defensive strategies. I have one slide on offensive strategies, and we probably need more data on this, but there is a cohort study called Cardia that followed individuals from early adulthood through later in life. And the interesting thing that they found was that higher baseline fitness when the patients were enrolled was predictive of higher lung function later in life. And if that fitness was maintained or increased, lung function was highest among those groups. And so we don't fully know why exercise is associated with better lung function. It could just be as simple as stronger muscles, breathing better, but there is some thought that perhaps there's an anti-inflammatory effect from tobacco smoke, and that actually could be driving some of the overall improvements over the life course that we saw in these patients. So the last thing that I'm just going to end with, which is the last little bit from the book I wrote 2 years ago now, and that is, if I just, if we leave you with one thing from this webinar, and that's that we've really, what I've come to realize is that we need to recognize the warning signs of lung injury much earlier than we had. I really think that the COVID-19 pandemic just made more clear the fact that we had a problem already to begin with, and that spirometry really isn't just a test of lung health, but rather human health. And I think as a community, we need to start thinking a lot more strongly about being much more aggressive with assessing lung function much earlier than we do, which is essentially often when a patient walks into our office and they're severely short of breath, and at that point, much of their lung function is gone. So I'm going to go ahead and stop there and ask Alex and Steve to come back on. I have no idea if we may, I don't
We
know.
have a few
We
questions,
have a few
MeiLan.
questions. Okay, we'll go
Yes.
ahead and start with some questions then.
Thank you both for your remarks and your insight. As for the first question, and either one of you can take it, as we look at the impact of climate change on lung health, is there any additional impact on rural versus urban populations or any correlation of outcomes related to socioeconomic status?
You want to go
You.
ahead? You can go
Yep.
ahead, Alex, if you want.
Sure. Yeah. Great talk,
We can't hear you, Alex.
Do you want to? You're a little bit
Apologies.
quiet. There we go.
There we go. Sorry. Great talk, Dr. Hahn. Yeah, and excellent question. So I'm not sure I'm able to fully answer, but I can offer a couple insights, which is to say that yes, I think the urban-rural divide is really important here, in particular because we know that the world is rapidly urbanizing. Something I think around 60-something% right now of the world lives in a city, and that's expected to rise in the 70%, 80% range, I think, in coming decades. So it's really important. From the climate perspective, why is urbanization a concern? Well, I think actually it's something that we didn't even really touch on today, which is heat. We know that heat actually by far and away, actually probably more so even than particulate matter, is the biggest killer related to climate change directly, and it's the thing that can be best studied from as a climate change effect. And cities, we know, especially with urban heat islands where temperatures can frequently be several degrees Celsius higher than surrounding areas where there isn't a lot of concrete, can be really major threats to our patients, and they have been linked to exacerbations of respiratory disease, heat alone, as well as other organ injury like renal failure. So I think that so yes, urbanization is a major concern. Still, rural areas have their own challenges, and I believe, and MeiLan, correct me if I'm wrong, but I believe rates of COPD are higher generally in rural areas in the country, in the U.S., and could be for a variety of factors, which I don't want to speculate on. But yes, I think thinking about this divide is important, and thinking about socioeconomic status is equally important, as I kind of alluded to. Areas where patients are more vulnerable, have less access to care, including, for example, in rural areas, or have other metabolic comorbidities, are going to be at higher risk to climate change effects.
Yeah, we could spend an hour on this question, but as Alex pointed out, that we do have higher rates of certain chronic lung diseases in rural areas, and I suspect it has to do with exposures as well as socioeconomic status and lifestyle. It's just you can't really separate them. There is a NIH study right now actually called Rural that's actually going out and investigating cardiac and lung health in rural settings in the Southeast United States. So one thing, though, that question actually made me think about, Steve, was your study, which, one of the things that we witnessed, it's not directly related to climate change, but I think it does relate to various societal factors that impact lung health. And that's just the fact that here in Michigan, we saw many more Blacks die of COVID-19 than we did than whites. And maybe some of that was due to vaccinations, but I don't think it could also have had to do with care that they received either during the pandemic or care for chronic conditions leading up to the pandemic. Steve had an excellent paper showing that other factors like inadequate pulse oximetry for individuals with darker skin could also play a role in potentially them not getting as much oxygen as they need in the hospital. So there's so many factors. That's such a layered question that I think can impact care. We've got a shortage of pulmonologists, and just allowing patients to get access to specialty care here in the state of Michigan is something that, just trying to see as many patients as we can. The needs are really great, and it's a huge challenge.
Thank you both. Here's a second question. We have heard that the COVID-19 pandemic may have had some positive impact on the effects of climate change from a societal standpoint. Is this true? And if so, did the positive effects persist?
Do you want me to tackle, or do you want to? I can start.
Sure, go ahead. Yeah.
Well, so, and Alex, maybe your understanding of this is different than mine. So my understanding is that we did see, because all of a sudden nobody was driving, everyone stayed home for a while. We did see some pretty immediate decreases in greenhouse gas emissions, decrease in particulate matter and air pollution. There were parts of the country where suddenly you could see where you hadn't been able to see before. And so I think we did see some temporary improvements, but I am not aware that that has led to any persistent improvements. I think we're kind of back to our prior patterns. But Alex, do you know otherwise?
Yeah, I agree. I think that we're largely where we were. Airline travel is pretty close, I think, to where it was beforehand. I was going to say the one area that this question made me think of was telehealth. I think the pandemic really, I think, changed the way a lot of us practice medicine and incorporate telehealth into our routine practice, as well as our how we carry on meetings and conferences and so forth. So I think that there may be some upside to that potentially.
Thank you. So far, I have only one more question. How can we begin to impact the negative effects of climate change right now?
Yeah, I guess it depends how you view how you define impact. But I mean, I think that there are there are, of course, individual actions that we take, and I think that personally I find that those are important because they as I alluded to, again, help us cope with some of the stressors and eco-anxiety and all of that that's going on around us. And so therefore, I personally find that taking local actions is really is motivating, and can hopefully convince others and promote change on a societal level. At the same time, of course, you know, we need to aggressively accelerate our energy transition. We are moving in the right direction, but we're definitely not moving fast enough. And those kind of decisions need to be made on the national, international stage. But individuals acting together, advocating, standing up, as MeiLan is doing to a great degree through the American Lung Association and through our professional organizations, American Thoracic Society. Our hope is that those can kind of bend the curve and make a difference. So I think it needs to come, again, just my own view. I think it needs to come from both sides, and I do think that changing the way some of the things we do that we know are going to impact the climate, like for example, eating less meat, very clearly is a very strong driver. Actually, I just heard a talk yesterday by a Michigan professor named Shelley Miller on this. It's really just like an order of magnitude as far as what the impact that can have on our own carbon footprint. So promoting like a better diet that's probably better for our health and for the climate. These types of things on the individual level, I think, are really important.
Yeah, thank you. So yeah, I would agree with that. I think maybe taking a different lens on that question. I think, from our patient's perspective, there's all the things that we talked about to try to, at least help protect them from the impacts of climate change. But I think when we think about it from a physician and a healthcare system perspective, what can we do? I think we as pulmonary physicians have to be a lot more active and a lot more vocal about just sort of about anything that's going to impact or harm the air quality, or even things like I said, city planning and where schools are built, and advocating for the health of our children and anti-idling programs. All of these sorts of things I think become important. And then there's other work, as Alex mentioned earlier, that it is true that there is some concern for some of the respiratory inhalers that we use and how they might be negatively impacting climate change. I think the good news is that many companies are working hard to get those inhalers switched over to environmentally friendly options. But having said that, I think that when we look at the impact of things like inhalers compared to all the other things that we do within the healthcare system, it's kind of a drop in the bucket. And that some of the personal decisions that we make, and like travel and how we conduct our meetings, and other impacts that our healthcare systems have on climate change are probably greater. But still, it's important to do everything we can. I see we've got another question that popped up, Steve.
To what extent do our politicians influence the progression toward a healthier and safer population? How can we spread awareness of the findings from the presented studies to the general voting population, given the increasing spread of misinformation regarding climate change?
Yeah, that's an excellent question, and one that I think we grapple with a lot. And I think so. Uh, You're absolutely correct that there are a lot of misperceptions out there, and misinformation has really spread particularly on climate, which has become such a politically charged topic. And we know from surveys, particularly from Yale has a center that surveys regularly surveys the population on views on climate, that it really breaks down along political lines. That being said, there is increasing recognition in areas of the country, even among areas that represent more conservative parts of the country. For example, in farming communities where climate change has just become so evident that minds are changing. So I think it's really important for us to continue to address this issue, and that's why we're holding meetings like this to try to get the word out to members of our professional communities, but also to continue to write and advocate and speak out about this issue in a nonpartisan way. I think is really important. I think the thing that I struggle with most is that we're oftentimes preaching to the choir, excuse me. And I think trying to find creative ways to communicate the risk is important. And I think actually health professionals have a unique vantage point because we're talking about health, which is, of course, that's probably, that's what we all have in common. It's like, we don't have your health, what do you have? So, so talking about this as a really human health issue, I think is probably one of the most strongest angles from which you can talk about climate. And so that's why I have found, I've tried to communicate this through that lens. But
I think you're absolutely right, Alex. Part of this is the messaging. I think one of the things that when I was thinking about why it's been so hard to get the word out about this, I think it's because everyone thinks about it as someone else's problem. So particularly when it comes to lung health issues. Well, I don't have asthma, I don't have COPD, I don't have pneumonia, nobody in my family, or maybe, great uncle Ralph had lung cancer, but I don't smoke. So again, not my problem. And I think what I hope people took away from this, and I think that the discussion that we need to engage with anyone who will listen, is that this is everyone's problem. This impacts pregnant women and children, regardless of what your behavior is. You live in the world, you will be impacted. And that nobody's going to escape. That was part of the reason why I thought the data regarding wildfire exposure and COVID-19 was so interesting, was because, through no fault of their own, here we have a group of individuals that was hit by sort of this natural disaster and then the pandemic at the same time. And we can really see in real time what those impact is. I think that that's probably happening on another level pretty much all the time, though. When we think about, why did this person get this infection or have this flare up at this particular time, it's difficult for us as physicians to always track, but I think it's often going on in the background. So I think the more that we can move the dialogue towards, that this is a human health problem, it impacts all of us, and we need to think, broadly about solutions. I can tell you that the division of pulmonary and critical care medicine here at the University of Michigan is working on engaging with, with state legislators as we can, as well as working with the ATS and the ALA on more national legislation.
With that, I don't see any more questions. I'd like to thank Drs. Rabin and Hahn for their remarks and their considerable insight. I do want to let you know, as a few business things, you will receive an email after the course adjourns with instructions on how to obtain your CME credit. We here at the University of Michigan look forward to interacting with you in the future for additional presentations. And we thank all of you for your time and your participation. With that, our webinar is concluded. Thank you very much, and take care, and go blue.